or the way we had talked about doing this, someone with intimate knowledge of the compound, in this case, Yoav Golan, is going to make a really brief presentation on the compound we'll talk about, ATI-2307. And he represents Appili Therapeutics. And Yoav, I'll give you the floor here to just present these slides briefly.
Thanks, Pete. Let me just share my screen for a second. All right. Okay. Well, it's a pleasure, and thanks, Pete, for the opportunity. Serving as a transplant ID doctor for many years, had a good opportunity to see some of the unmet needs in antifungals. So I'll keep this presentation brief. I'm not sure who's joining us, and would appreciate any comments and any suggestions and any thoughts. So I'll be presenting some of the preclinical, a little bit of preclinical, and some of the early clinical data with the face forward, designing our advanced clinical training. A little bit about 2307, and some of you know the compound pretty well, you for sure. You can see the structure of the molecule here. For those who structure resembles other antifungals, it is somewhat resembling pentamidine, but it's different in quite a few ways. It was first designed by Fujifilm Toyama in Japan. It's being developed by Appili. It's a small company out of Canada. The mechanism of action for 2307 is unique. It's a toxin for oxidative phosphorylation. So it starves the microbes from ATP, and by that it causes their demise. As you probably know, ATP is mostly generated through oxidative phosphorylation, so glycolysis cannot really salvage that very well. But the point is that it is a selective mechanism. Obviously, we as humans require mitochondria as well, but it does that far greater extent in fungi. There is data both from radio-labeled carbon and several studies that show that 2307 concentrates in fungi to a much greater extent as compared to non-fungal animal or different animal cells, hepatocytes and others. One study showed a 4,600-fold concentration in Candida as compared to extracellular medium versus only 35%-fold concentration in rat hepatocytes. Again, suggesting that it's highly selective, and the selectivity, of course, is of vital importance to prevent toxicity, as we depend on our mitochondria as well. A little bit of in vitro data, some collections of Candida isolates, as you can see here, as well as crypto isolates with MIC90s and MIC ranges in some of the cases presented here. In the range of usually a single to double figure nanograms per ml or fractions of micrograms per ml, as you can see here, with activity which is broad and includes both susceptible and non-susceptible Candida species, including fluconazole, caspofungin-resistant Candida species, some glabratas, oris, cruzii, parasilosis, and others. And you see that the susceptibility remains very high for all of those different species. Looking at crypto, you see the MIC90s here for neoformans and gattii, a little higher for gradii, but just a tiny bit, and still very low MICs for both cryptos. Going to the right, you immediately see that the Aspergillus fumigatus susceptibility may be borderline in terms of micrograms per ml in comparison to the concentrations that we typically achieve. You see other mold susceptibilities as well. And then in the bottom, just adding for crypto, 3 different strains of cryptoneoformans, some information on fungicidal, not just inhibition activity. And you see that it achieves fungicidal activity in the range of 15 to 30 or to 62 nanograms per ml, or a fraction again of microgram per ml. So the bottom line is that it has very high in vitro activity against a broad collection of yeasts and molds, but it doesn't include all, and particularly not Aspergillus fumigatus. Whether this translates into in vivo activity in animals, I just present a tiny bit of data here. There were 45 studies that were completed in animals, so a pretty large number. In mice and in rabbits, the 2 types of animals, and you see here the dosing range, which is equivalent to a highest dose of humans of 20 milligrams per dose by extrapolation. You see here the type of studies in Candida and in crypto in terms of the endpoint, whether it was survival, fungal burden, or both of those. And then I just present 2 studies as a quick example. On the left, you see a intranasal inoculation of a high inoculum crypto in immunocompromised mice, where the comparison is between placebo, fluconazole, 40 milligrams per kilogram, amphotericin, and 2 different doses of ATI 2307, looking at both survival up to 55 days post-infection, as well as brain fungal burden. When you look at the fungal burden, you see that the decrease in inoculum was pretty similar between amphotericin and fluconazole and the 2 doses of 2307. When you look at survival, obviously it was the worst in placebo-treated. Fluconazole treated mice with the second worst survival. And when you look at the survival for 2307, it was 80% for the lower dose of 1 milligram per kilogram, and it was 100% in the higher dose of 2 milligram per kilogram. And this is only one of the studies that suggests that within that range, increasing the dose translates into better activity. On the right is a crypto meningoencephalitis study just completed by Dr. Perfect at Duke, not yet published, in immunocompromised white rabbits, between 2 and 7 rabbits per group. Again, skipping some of the information, but looking at fungal burden in the CSF in this particular case over time post-infection, comparing untreated, fluconazole-treated, amphotericin-treated, and then you have 3 different doses of 2307, 1, 2, and 3 milligram per kilogram, as well as a combination between 2307 and fluconazole. Obviously, the worst doing were the placebo-treated, with all the other treatments having some level of efficacy when looking at burden, with highest burdens decreasing with the combination of 2307 and fluconazole, as you see here in pink, but pretty substantial decrease in inoculum in the 3 different doses of 2307, a little less decrease in inoculum observed with amphotericin, and less than that with fluconazole. So again, those studies kind of replicate their results, suggesting that the high in vitro activity translates into in vivo activity. And in the example that I use here is the crypto studies in both mice and rabbits. This is a little bit of PK data without getting into the details. You can see that steady state is achieved pretty quickly, and the max or the peak concentrations are typically in the hundreds of nanograms per ml, with the minimum concentrations in a range of 1 to 10 nanograms per ml, and you achieve higher peaks with higher doses. And the cumulative excretion, about 12.5% are excreted in the urine, with 5% in the feces, and the rest is is excreted in ways that haven't been yet characterized. So plans for clinical development. The plan for Appili to develop 2307 is for life-threatening infections, yeast infections at this point, with advanced plans for cryptomeningoencephalitis, HIV in Tanzania. Endpoint is death and CSF fungal burden. The comparator is going to be the combination of ampho and flucytosine, and step down to fluconazole, as well as invasive candidiasis, mostly candidemia, obviously, would focus on hard-to-treat candida species such as glabrata and auris, US, extra-US, possibly with an endpoint of death, clearance of bloodstream infection, with the comparator perhaps being canocandin. There may be some for non-indication, and this is really a place where we would appreciate a lot of advice as to developing it for Candida UTI and pyelo, true UTI and pyelo, perhaps fungal keratitis in other directions. So I have a few discussion points, but I think this would be a good time for you, Pete, to take it back and direct the discussion.
I do have one question about your presentation. You mentioned in your list of fungal pathogens, there was an acanthamoeba species. Is that the protozoan? And does that connect to the, there we go, acanthamoeba polyphagia. Is that the, does that connect to the exploration of keratitis as a therapeutic target?
No, typically, no, I don't believe so. I don't believe so. This preceded, so I was
just curious.
Yeah.
Okay. All right. Well, I mean, we in the MSG have looked at this, and we've thought this compound has really enormous potential for drug-resistant Candida species, and have proposed a protocol whereby we would enrich it with patients who have Candida auris, Candida krusei, Candida glabrata, especially, and try to get this really targeted into that population. This really seems to be an area that this compound could potentially really fill a niche, because especially in areas of the world where there's triple drug resistance, that is to amphotericin, the echinocandins, and the azoles, there's really not much else you can offer patients with auris. And so this seemed to us to be a good target, and we've been exploring this and have a R34 to work on a more complete application. Just FYI, we have submitted to the group at Emory, the emerging pathogens group, and hoping to hear back from them soon as to whether this is we go to the next step with this. Yoav, let me ask you a question about the compound vis-a-vis crypto. How do you guys seeing this being developed in crypto? There are a lot of agents out there. And what do you think the potential advantage would be to, a population with cryptococcal meningitis that would provide, benefit over and above what's currently out there? I think it's an important question for you guys to answer, just internally.
Yeah. Well, interesting enough, I had this question as one of the questions for discussion, and I was hoping to get some comments. I guess it has to do with what is the real unmet need when it comes to crypto. We all call it meningitis, but every time I call it meningitis, John tells me that it's not meningitis, it's meningoencephalitis.
It is meningoencephalitis.
Now I call it encephalitis.
Yes.
Well, I don't know how to answer that. It's I think it's a combination of opportunity and need. The fact that AMPHO is our first line for crypto, with AMPHO being so toxic, I think answers your question. So is there an unmet need? I mean, I think anyone would like to replace AMPHO. I don't think anything is going to be better than AMPHO, but I think it's going to be less toxic than AMPHO. So I guess your question is more relevant to the competitive kind of landscape. I mean, the other compounds that are coming, and whether there's going to be an unmet need once those compounds come into the market. And of course, we don't know, what's going to, whether it's Martinez or, what's going to come into the market. And so, but I think as far as we use AMPHO as first line for crypto, there's always hope for better therapies or less toxic therapies. I mean, I'm not sure, your question is particularly good because in developing countries, AMPHO obviously is very, very low cost and will always be preferred if you can manage toxicity in developed countries. That may be much more of an advantage, but we don't see that much with crypto as we used to see, for sure not in immunocompromised and HIV patients. So there is an opportunity because we're already aligned with the study and with David Bowler in this for that purpose. But your question is really a good one. I look at 2307 as a lifesaver potentially for hard to treat candida, and I look at its crypto data mostly within the context of how does that inform our candida studies and our candida experience to some extent. So, what do you?
Well, no, I think it's even more germane at this point because of the way in which amphotericin is being used in especially in resource limited areas where it's being given as a single dose, a high single dose, a 10 milligram ambisome dose, given once or twice over a course of a week. So, I mean, they've already made it easier to administer amphotericin with much less toxicity. So then the issue just becomes, the infusion toxicity, the cost, et cetera. It's just, I don't have an answer. And I'd certainly like to see the information. I'd like to see a study done, but as a parenteral agent, you do have to wonder, where this fits ultimately in the overall scheme of things.
But I wonder if I might add a few things, Pete, also. I mean, certainly as we look at all the non-clinical models, we perform very well in our mouse models and our rabbit models relative to AMPHO-B. So we look at that and say, okay, we can play in the same area when it comes to efficacy. There are some unusual PK characteristics about this that we're trying to sort out with the help of a PK modeler. And there may be some opportunities for, again, looking at different dosing algorithms or the potential to allow long carryover effects. So those are some of the things that we want to explore as we're getting ready to think about phase 2 programs and how we go about administering the product.
Are you considering? I know in our initial proposal we suggested twice daily. Have you any new information suggesting that once daily? I mean, this is a long half-life drug. We do know that the elimination half-life is very long, and so I wonder what new information, if any, you have about dosing frequency.
Yeah, so the dosing frequency we haven't been able to model yet, but we have looked at some recent efficacy experiments that John has conducted for us, looking at less frequent dosing, and the efficacy is quite comparable. What we want to do is then to model that out and say, might that look like in humans? So it appears that there's the potential there, but we just have to do a little bit more work. We haven't gotten to the point yet where I can give you a definitive answer on what we're seeing, what we think.
Just to add to that, I think, remember in POSI, how we used to dose POSI 3 times a day, even though the half-life is 36 hours because of the bioavailability.
Right.
Obviously, bioavailability is not an issue with 2307. It's given intravenously, but we may need, we don't know, but we may, and we are actually repeating and pushing the dose with another phase 1 study. We may need to dose more frequently just to be able to get more into patients, avoiding some of the potential of giving too much together. So we'll have to, but that's definitely, so, we try to develop it as a convenience antifungal, and it's possible that less frequent dosing. John, I mean, just to answer you, the crypto, John Perfect is very enthusiastic about 2307, not because of the hard to treat candida, but because of what he has seen in the CSF of those animals that he treated. He said he never, I mean, I don't know if I'm allowed to cite.
No, he has shared this with me. I understand he's really enthusiastic.
You've seen that.
Yeah, he has never seen such a response. And, plus not to mention the fact that CNS activity may be important in some patients with candidemia as well. Joe just talked about the fact that we suspect endophthalmitis far more often than it happens, but some patients do have it, and you may want to rely on it. So for all those reasons, I think there's also an opportunity. One of the problems is that if we just do a candida study, it's probably not enough to do just an invasive candidiasis study to get approved. I mean, you probably need a second study. And I don't know if esophagitis, which was traditionally done, with most antifungals as the safety database kind of producing study, I don't know if this will be a good fit for 2307. And so there are quite a few reasons that related to the opportunity with crypto.
Yeah.
But I think that we can still change this. It's we are open. I mean, we are open, and that's part of the reason we were so motivated to present here. To know what people thought.
Okay. Esophagitis and mucosal disease is I wonder if that target as a viable study target has moved on. Even in the developing world, there's still some around, but there's far less than there used to be. That's for sure.
It used to be.
And you do run into the issue of just feasibility.
Used to be the UTI of antibacterials. The easiest to study, to enroll, to have a large.
Yeah.
What do you think? What do you think about UTI?
Well, I was going to say that among the non-candidemic Candida infections, I think, tell me, I'm waiting for somebody to tell me how to treat a Candida glabrata, Candida krusei, or drug-resistant, fluconazole-resistant UTI. It's just impossible to do safely and confidently. Nobody wants to infuse amphotericin into the bladder. And so, we just don't have a great option. And so having something that is, gets in the urine, even though it's not excreted entirely in the urine, but that's not a small amount. I mean, 10, 15% excretion is better than I would have anticipated. And that may be enough just to get there. And to cure a Candida glabrata infection. That's really those are a bear to treat. They're just really tough to treat. So I think it, and those patients are, while they're not abundant, you're not going to have a difficult time finding them. You won't have a difficult time finding them.
So a quick question about the UTI indication. This has been really intriguing us for a while too, and we were looking at the numbers like you did and saying, okay, we're getting some in, but that is the actual excretion into the urine itself. We know when we look at the non-clinical models and the distribution of the drug with whenever we radiolabel it, we see kidney is one of the major organs that lights up when you put C14 in, and it's not because it's in the urine. It's just loading into the tissue itself. So even though there is very little that may be excreted there, it could be that it's getting into the tissue anyway. Where do you think the glabrata and things like that are best treated? Is it in the tissue or in the urine?
That's a good question. And I mean, if it's in the tissue, you could argue that an echinocandin would be okay. And maybe that explains some of the success that they've had. But my feeling is that we're probably dealing with mucosal or vesicular disease, bladder disease, more than anything else. Upper tract disease, you would take a different approach. But in truth, it's difficult to localize these, in my view. I mean, it is difficult to localize.
And so for us, then the fact that we load into the kidney and we are excreting the urine may, hit it from two
It
different.
may be a real
directions.
advantage. It could be an advantage, and maybe reason enough to want to design a study after that.
It's an interesting indication because in my practice, and I see few UTIs, pylos, Candida UTIs, pylos that I believe, but I see many that are being treated.
Yes,
and so
yes.
there's this huge discrepancy. I wouldn't say it's like Candida in the sputum because I think that
No, that's a different thing altogether.
But it's like the patient has a little bit of fever. The reason is not clear. The fever doesn't go away with antibiotics, and there's always Candida in the urine. Not always, but very often. And then prove that it's not a cause of the fever, and then it's just so often. Yeah.
We're being drawn out of the room, but I would say that that the urinary candidiasis is really an intriguing option, and one that I would like to see you pursue that. I think that would be interesting and potentially fruitful. So, but we're being pulled back into the room now. I thought that was a good discussion.
Yeah, thank you.
Thank you, guys. Thank you all. Thank you very much.